How do I know it's time for surgery?
This is more than just the normal tweaking, of their back. We make a small incision, and through that incision, we insert a tube.
So It's incredible work. Now, we need to talk about a question every patient eventually asks. How do I know it's time for surgery? Most people don't want surgery. It's scary, it could feel overwhelming, it could be exhausting. So let's make this simple. Dr. Woods?
Yeah, surgery is not the first option. As I said, most people are going to get better on their own. But sometimes the nerve is so traumatized, has been injured to the degree that it's not going to recover. And at that point, it's not a matter of rushing into surgery. It's more a matter of preserving integrity and the function of that nerve and preventing any consequences from letting that go untreated. So there's some really clear red flags. If someone develops weakness, for example, a good example of that would be sciatica that's causing a foot drop, where they can't lift their foot, the toes are dragging. That's an issue that needs to be dealt with because it can lead to permanent neurological deficit. Also, if people have issues controlling bowel and bladder, now there are a host of things that can do that, some of which are not spine related. There are urologic problems and others. But if there's an issue where people are losing control of bowel and bladder function, that's an emergency in many cases if it's spine related, and we want to get to the bottom of that. And the other thing I would say is quality of life. It's one thing to put up with a back issue and with a disc issue and with sciatica if one is able to carry on your normal life and take your family and work and enjoy your hobbies. But when that issue starts affecting quality of life, that to me also is another key time when it's time for us to think more seriously about surgery.
Yeah, if we see enough patients here, we kind of see how they do get to a point where their work, they cannot get to work, so they have to take narcotics to just get through the day. You're not, if you're a mom, you take care of your kids, you can't, you take narcotics now, that's a problem. You can't really do certain things when you do that. So I can see how, that's, I would say, unless you have, the emergency signs you just listed, if your quality of life is impacted, I can see how, that's, but a lot of people are afraid. When you say surgery, it's, surgery can mean anything. It can be mega surgery, big surgery, small surgery, hours surgery. So I can see how people hesitate, even when they're in pain and the quality of life is impacted, to come in to see you. Mm-hmm. And hopefully with this episode, we will really try to debunk some of those myths. Surgery, spine surgery, it's scary, and the recovery takes forever, or I've heard this neighbor or that neighbor have surgery. Because there's a lot of misinformation, I feel like, out there. Spine surgery is the right step for the right symptom and for the right people. And the results are amazing.
Yeah. I think there are two categories. There's the person that comes to me knowing that they can't carry on like this and something has to be done. And they know their body well enough to know that this is more than just the normal tweaking, of their back. So there's that person that comes in and says, hey, I know that you got to fix it and I want it done. And you mentioned the other person who probably knows the same thing, that probably something is not quite right and needs to be fixed, but they're just terrified of surgery. And I understand that. I don't think that anyone in their right mind just surrenders to the knife and to having surgery and being on the anesthesia without a certain amount of hesitation and fear. So, and that's where we come in. It's what we do every day, and our job is to take them by the hand and lead them along through something that's terrifying, and lead to a final place where they're happy that they did the surgery.
And you're right. A lot of our patients feel like when they come to you, and we get a lot of feedback, they say that you actually try to talk them out of surgery a lot of times. And I think, tell us a little bit about that, maybe.
Well, it depends on the problem. So as we talked about, not all disc issues are the same. Sometimes the disc is just a bulge. Other times there's a large fragment that has squeezed its way out, the extrusion of the disc or sequestration. And sometimes there's no way around fixing that. So it depends on the scenario. There's sometimes when I do go immediately to surgery because based on my experience and my training, I know that this issue is not likely or it's highly unlikely to get better. And looking at the amount of suffering that person is experiencing, I recommend surgery immediately. There are other times, though, when the issue is not as severe, and I'd rather give it time to see if I can avoid surgery and get things to heal on its own. So it is not a black and white picture. I think that's why it's important to see an expert that can look at the MRI, look at the individual, talk with them, do a really good assessment and physical exam, and tailor that plan to suit them. That's that personalized care that we're so big on here at Virtue.
So next, we're going to talk about the surgery that we do for this herniated disc, which is a minimally invasive lumbar microdiscectomy. And it's micro for a reason.
Yeah, so this surgery is minimally invasive. And there are a few things I need to mention about minimally invasive spine surgery. Number one, the incision is smaller. So most of these surgeries are done through an incision that's less than an inch. And that's very, very different from spine surgery as it was done in the past. The second thing is that because the incisions are smaller, there's less trauma to the tissue beneath, there's less pain, there's less bleeding, and there's a lower chance of an infection with surgery. And the other big category is that patients are up on their feet the same day. These surgeries are done as outpatients. They go home after surgery, and the recovery is faster. So that's just to set the stage, minimally invasive surgery in general. Now, for a microdiscectomy, so if we look at this model, we see how a herniated disc, which is this spot, is pushing on the nerve, which is that orange portion here. And with the microdiscectomy, the goal is to remove this fragment, this ballooning fragment right here.
I can hold that?
So, yeah, you can hold that. So let's use this, this model. And this here is the skull, the cervical spine up top, thoracic, and lumbar. We're kind of focusing here on the lumbar issue. So we can see that there is a disc herniation, just as we mentioned before, that is pinching the nerve, and the nerve would be like these structures, and there's one that's in this area here that's being pinched. So what we would do is the patient is on their belly, okay, kind of like this, and we make a small incision, and through that incision we insert a tube. So that tube comes down through the skin incision, and it sits on top of the bone. And this is all attached to a retractor arm that holds that tube in place. But the rest of the surgery, if I turn this here now, you can actually see. I don't know if you were to zoom in on your camera, if it gives you sort of like if you can get closer to that tube and see and imagine, from your perspective there, what it's like. But really, from my perspective, what this looks like in surgery is that I'm working down through this opening, through this tube, with the microscope with a lot of light down into that one spot, and I can, bring instruments into that tube. So again, if you've got the perspective here with your camera, we are able to take an instrument. This here is like a forceps type instrument and also has cautery. Introduce that down into that tube and work through that tube. Here's another instrument that's called a pituitary rongeur, and it's an instrument that's very good at grasping bone and the herniated disc fragment. So we are able to introduce this instrument here down into the tube to grab, if we were working on that, grab that disc material and remove that. Now, I'm clearly making this a little bit more simplified, but you can see how we can get that work done through a very, very small opening. And then when we take that tube out, the muscle just comes back together as though we weren't there. So it's a very elegant way to get to the spine, all the way down to the bone, not disrupt the muscles, cause minimal trauma to the soft tissue, and then when we leave, it's like we weren't there.
Of course, some of the patients are, you know, you have to go deeper. This tube is actually longer, but this is the diameter. And if you put anything through it, everything goes through it. So
Yeah.
it's incredible work.
Yeah, it is. It truly is. And there are other ways, too, that this stuff is done. You know, this is a tubular minimally invasive option. Another minimally invasive option is endoscopy. So that's another one that is sort of kind of gaining popularity, but it's very slow, and the learning curve is steep. And so we haven't seen endoscopy penetrate, you know, the nation everywhere. It's not something that we do currently at Vertray, and that's because we have a lot of experience with using these tubes, and it's extremely non-invasive to use these tubes, and we believe in that philosophy of using the microscope and versus the endoscope. So it's not to say it's a better, you know, than the other option, but it's just something that we really believe in as part of our philosophy here.
And I know you also do, if somebody has a larger herniation or a bigger hole, let's say, you also offer something else. It's something new that not every center, like in the country
So that's
does.
getting to this device, the Barricaid device. And what this does is it plugs the defect in the disc. So this is the front here, this is the back, and we're looking at a spine that has been cut in half, and this is the disc material. So if there's a herniated disc, that's when this stuff here is protruding back towards the nerves. After we've gone in with our tube and we've cleaned everything out, there's still a hole left inside of the disc. You remember us talking about the outer annulus of the disc, and we talked about the inner soft material called the nucleus.
Oh, the jelly in the donut.
That's right. That jelly
Yes.
can still squeeze through
I see.
because there's an opening there in the dough, which is that ring.
Got it.
So this is where the Barricaid device is able to plug that hole and to repair the annulus in a manner that provides immediate prevention or near prevention of recurrence of the problem. Because that was one of the issues. Without the Barricaid, the problem could recur.
Especially
and it's not
if you're
that
active.
it can't now, but it's taken that down to a very, very small, negligible number where it's almost fair to say that we've prevented these from occurring.
Okay. Yeah. So I do know we had some very active professional players getting this procedure, and college players, high school players, all kinds of sports. So we have our own real success stories.
Yes.
We've
got a mini series here of college athletes
Yeah.
that have had microdiscectomies with Barricaid, and they have done a various sports, from volleyball to baseball, including pitching, football, wide receivers, and others. And it's been, you know, golfers, it's been very successful in that patient population.
So do you ever do microdiscectomy without a Barricaid, or it's usually it's your go-to, or is there a particular population you have in mind for Barricaid, or how do you?
There are a couple scenarios when we would avoid using Barricaid. One is if the disc is very collapsed to start off with. So bone and bone, the disc is in between. If that bone is very collapsed, less than 4 millimeters of height of the disc, then, yeah, exactly. Then it's not feasible, at least with the current indications that set with the FDA and current instruments that we have, it's not feasible to do the Barricaid in that scenario. Okay. Another scenario would be if the defect through which the herniation happened is so small that the Barricaid device is not needed or can't really fit into that space. You know, there are others. If somebody has extremely poor bone quality osteoporosis, the metal pin that's there probably, would not work very well. So those are some of the indications. And always we need to think of who's paying for it. So there's some insurances that do not reimburse for the Barricaid device, or the reimbursement is actually less than what it costs to put the device in. So in our case, when we are the surgeon, but we also are the center, the facility, the surgery center,
Yeah.
it's important for us to think about, we'd love to be able to do it, but we have to be able to at least cover the cost of the device. And that's interesting to think that sometimes the reimbursement could be less than the cost of the implant, and that's a very challenging scenario. So in cases like that, we let the patients call and talk with the insurance and try to figure out how to work around those scenarios. So those are some of the common reasons why we would not place a Barricaid.
So then it would be fair to say microdiscectomy removes the fragment, and if your hole or like defect is too big, then hopefully we can do a Barricaid. And hopefully your insurance pays for it. If not, it might not be possible. Once someone hears they're a candidate for surgery, their next question is, what can I expect after surgery?
Well, I think the first thing I got to say is that everybody's experience is a little bit different. Having said that, I'm gonna make my comments based on the 90%, what most people experience. So most people that have surgery for a herniated disc wake up feeling much less pain than when they went into surgery. And that's unique because most surgeries, let's say a hip or knee replacement, for example, it's normal that you wake up with more pain than you had before surgery, and then eventually things get better. But this is one of those where immediately that sharp sciatic pain is usually gone. But what's new, what's there that wasn't there before, is the soreness of the area in the low back. And so we tell most people that they should take it easy for up to 6 weeks. And that's especially important because we don't want things to re-herniate.
Yeah.
And during that 6 weeks, if there's not a Barricaid device, there's that open hole that needs to scar and to seal off so that a re-herniation does not occur. Barricaid does help a lot with preventing that problem. So in those patients, we really allow them to do as they can tolerate. And we let their body guide them as to what activities they can and cannot do. By 6 weeks is when we lift all of the restrictions and we allow them to go back to lifting and bending and twisting and doing normal things. And we also recommend physical therapy because not only do we want to work on strengthening their back muscles and improving their flexibility, but we want to work on their legs. If they've lost any strength in the muscles of their legs, or maybe they had numbness or different things and their gait was affected, we want to retrain all of that. It could take up to a year for nerve healing to occur. So what happens with a disc herniation is that it injures the nerve at the point where the nerve is pinched. So we've got that disc and we're pinching it, and it injures the nerves. And a nerve is, we think of a nerve like a telephone wire, where there's an outer insulation, but within that there are a number of copper fibers. Those are the axons. And several of those axons die. The neurons die from the point of injury down to the muscle. And fortunately, there's still a sheath, a conduit, through which the nerve can regrow. And it grows an inch every month.
Wow, that's not fast.
So it's going to grow from the back an inch every month to the target muscle. And you have to grow enough of those copper wires to get enough signal to the muscle that there's strength, and if not muscle, to the skin to have sensation and so on. So people have numbness and tingling that could go on for many months, and some of it can be permanent. And that's one reason to not put off the surgery, is if there is an issue that's going on, that severe numbness, pain, weakness, like I said, is a red flag from the get-go. We want to get to it early enough so that the issue doesn't become permanent.
Yeah. So I can see how, because I guess that's the first question people ask, well, how soon until I can do the things I did before? And I guess another question would be, well, how long did you wait? Because if the nerve is really slowly dying, by the time the patient see you, it could be months, years. Do you see patients years after an injury, or how?
No, I think by about a year.
About a year.
About a year, I consider that people have healed. And if things are not better, then it typically is going to be a permanent problem. Now, have I seen this take a year and a half and got slowly better? Yes, but there's probably a little bit of a gray area between the 12 to 18 months. But after a year, typically, they've maximized the nerve healing.
Yeah. And I guess I want to also clarify, there's the recovery timeline, because we're talking about recovery, but also is, the question is how long people wait to see you when they have symptoms. So for example, if, I had numbness and tingling and continues and it gets worse, maybe over a year or two, because people do wait. Some people come see you immediately, but people wait. So I get a feeling that the longer they wait, the longer their recovery might be too, correct?
Yeah, but I want to be careful not to do this. I don't want anybody listening to this to come see me out of fear. I think the opposite is true. A lot of people don't come to see us because they're afraid of surgery. I don't want the opposite to be the way that we get people to see us because they're fearful they're going to lose their leg. No, that's not the issue. Most people, this is the problem that is gradually progressing over time, gradually causing repetitive injury to the nerve. I think that the reason to come in is not because of fear of permanent injury, but it's when that issue is not getting better. That you've got that issue that you've rested, taken some over-the-counter things, etc. It's not getting better. Get it checked out, because there's a quality of life component I think that's more important. And yes, to agree with you, if it's untreated for a long enough period of time, then they risk the permanent injury.
Yeah. We're talking about recovery, so I just wanted more to clarify. If you had the issues for a long, to me, my understanding is if I had that issue for a year, it's not likely expect it's going to get better in a month, because if the nerve is damaged, it might take a few months, it might take 6 months, 8 months,
that's
a little
correct.
Longer. So
as far as expectations,
right,
I think it's
the
important
recovery
to know
timeline.
that if the issue's been there for a long time, and or if the nerve is severely injured, that it can take many months or a year to fully
get
recover.
It back to the full, And physical therapy helps.
Absolutely, yeah. Physical therapy is a big part of that recovery.
Yep.
And in preventing other down the road problems, because when that disc herniation happened the first time around, it's many times because of improper lifting or movement dynamics. It's sometimes because of a lack of proper core health. And so therapy then has a role in preventative medicine so that person doesn't have that issue in another spot. Although they've had it repaired in that one area and the Barricaid device is going to likely prevent it from recurring, the same issue can happen elsewhere.
Somewhere else in
their
different.
spine.
Okay. All right, so before we dive deeper into the PT, would you just briefly tell us when should one worry or call us after surgery? So here are you in your recovery timeline, maybe you're a week or 2 weeks or a few weeks out and things are just not going well, or patients maybe feel like, wow, I've been improving and I'm going down. So can you talk a bit about that?
Yeah, so the reasons to call us after surgery would be if patients were getting better and then they had a sudden worsening. That's usually a red flag. That could signal that they've re-herniated or re-injured something. So on the other hand, if symptoms are getting better, but there are lingering problems, it's okay to wait. It's very typical to have numbness and tingling, occasional pain, and that pain could be in the legs or even in the back. So that can happen off and on, having symptoms like that are gradually getting better over time. That's all okay. But if things flip where instead of getting better, things take a turn and things are getting worse, especially if there's a sudden worsening, then that's something that we'd want to know. And there are more obvious things, like if there's an issue early on in surgery with drainage from the incision, any redness, fever, signs of infection, the very common things that people I think are should be aware of, then they typically would give us a call. But the thing that they may not plan for or think about as much is, hey, I'm getting better and then things took a turn. It could be that they're overdoing with their activity, but we need to know, we need to be notified so that we can guide their steps.
From our conversation, it sounds like surgery isn't the end of the story, it's the beginning of getting your life back on track, how we like to say it at Barricaid, as well as getting back to everything that people want to do.
Yeah, surgery is not the end goal.
Yeah.
It's a way to get people back to their normal life and living that true version of themselves and being fulfilled. So it's a beginning of a new journey for them, that journey back to health.
So if you watch this full breakdown from anatomy to imaging to conservative care, injection, surgery, and recovery, our hope is that you feel informed, reassured, and in control of your spine health.
Yeah, you don't have to fear disc herniations, is what we wanted you to hear today. You don't have to live confused, and don't feel like you're making the decisions all on your own. We're certainly here to help and to be your quarterback.
If you're struggling or unsure, reach out. There's always a path forward, and you don't have to walk it alone. We're here for you.
Yeah, take care of yourself, keep moving, and we'll see you next time.
Till next time.